So in this lecture, we're going to talk about coronary heart disease, which is the biggest killer in terms of cardiovascular disease. And it's what we would call a heart attack. So because there's a few people away, I'll just show this video for those of you that are here, which explains things.
Brought to you by the British Heart Foundation.
Sorry for the quality.
Hello. So you're here to find out what it's like to have a heart attack. Well, we don't have much time because with heart attacks you never do.
Let's start with the first symptom most people think of.
Yes, chest pains. Well, we've all heard of the classic chest pains, but they not always be that severe.
It could be a bit of tightness or discomfort in and around.
No doubt you'll shrug this off. I mean, slight chest discomfort, tightness, not worth worrying about, right? Wrong. What if it spreads to your arms? Still not convinced you're having a heart attack? Or what if you feel lightheaded? Oh, still thinking, don't make a fuss. What if it spreads to your neck?
To your jaw.
You're probably thinking, tough it out, it will pass. What if it doesn't? The longer you leave it, the more your heart dies. Don't kid yourself. If you're having chest pains or discomfort with any of these symptoms, or even if you're feeling unwell, dial 999. The ambulance service would rather see you and discover it's not a heart attack than arrive too late. Every second counts. Embarrassed if it's not actually a heart attack, but imagine how you'll feel that it is, and you left it too late. Imagine that.
So the British Heart Foundation have always had a thing about adverts attempted to shock. For the last few years, they've actually had quite cuddly adverts with disco dancing with Vinnie Jones and that kind of thing. But if you've seen their latest advertising campaign, I think they've moved back to having that kind of shock statistic or shock tactic. But actually, that video really gives you the key information that you need to know about someone perhaps having a heart attack. And that's really cover here. Now, before I start talking about coronary heart disease and heart attacks, just going to give you a little bit of introduction into the heart and its circulation. So that's quite important to consider. And then I'll talk about the various different coronary heart diseases. Just going to focusing on angina, myocardial infarction. I'm going to talk about some of the drugs used in these diseases and how those drugs work. What I'm not going to cover too much in this particular lecture is exactly what the strategies are for treating coronary heart disease. I'm going to direct you into the direction of the NICE guidelines, but I think the PBL activity that I was talking about, and also in the integrated practical, the case study you're given there, will force you to address a lot of those issues anyway and engage with that material. So that's not going to be covered in this lecture. And also, you might think this lecture is quite boring anyway, but it would be incredibly boring if I started talking about all the different stepwise treatment plans. Much more you can figure it out for yourself. So hopefully you're familiar with the structure of the heart. What I've kind of shaded over is obviously that the heart is very metabolically active and it requires its own dedicated circulation. So there's actually branches directly from the aorta allowing oxygenated blood to supply the heart. Now I've sort of highlighted some of the major artery paths. Arteries tend to coronary arteries tend to be named by which ventricle or which side of the heart they supply, whether it's the right or the left-hand side of the heart. And they tend to be named based on the branching point. So I'm not expecting to remember all the different names of the coronary arteries. It's probably worth realizing that it's the right and left descending coronary arteries that are often the site of blocks or problems in the blood supply to the heart. And you can see there's lots and lots of branching points here, and it's those branching points where the arteries divide that also tend to be a problem for blockade. If we talk about the sort of first ischemic heart disease, we often talk about, in terms of the progression of coronary heart disease, we talk about angina. I think what I need to make really clear is that while we often talk about angina as a disease, it's actually more accurately a symptom of coronary heart disease, because what's happening is it's the ischemia that's causing the angina pain. Angina is the pain that occurs when you have insufficient blood supply to the myocardium, that's the muscle layer of the heart. So if you have insufficient blood supply, you have insufficient oxygen. And the pain of angina, it can be mild to incredibly intense, causing you to faint, vomit, things like that. So it is quite a varied symptom. And when we talk about angina, a bit like in the video, generally we talk about a typical distribution of the pain. And normally we're talking about a pain in the chest, a pain across the left of the chest, spreading down your left arm and perhaps up into your neck. And actually, while that is probably the most common pattern of pain, it's another reason why lots of people ignore angina, because it could just be a pain in the chest. Some people feel it as a pain in their back. Some people only pain in the neck. Some people get pain going down their right arm. So really, if you have any pain in your chest and your arms or neck and back that doesn't have an obvious explanation, it's really important to consider whether that might actually be a cause of angina. And you'll get lots of elderly relatives. Lots of people just go, oh no, it's just indigestion, and say, oh, it's my bad back and things like that. And actually they're suffering from angina, and the first time they realize they've got a heart problem is because they've actually gone and had a heart attack. So it's not been diagnosed until they've actually had to go to hospital. And if you know the signs, it's pretty obvious. Now, if you've got indigestion or back pain, that doesn't normally get accompanied by pallor, which is paleness. Sometimes you get profuse sweating, like literally beads of sweat dripping up on people's faces and everywhere. They could also be very, very breathless. Now, all these symptoms could also be symptoms of something else. And again, that's another reason why lots of people just kind of almost laugh it off as something else and then find out they've had a heart. So if we think about angina, it's classed into sort of several categories, and they're roughly along the lines of severity. The sort of first type of angina that most people get is stable angina. Now, this is a kind of very predictable, or often very predictable pain. So quite often, if someone has to walk in the morning and they're constantly getting chest pain, like they have to walk to get the bus, they don't normally do much exercise, and when they do some exercise, they experience pain. That's characteristic of stable angina. Very common in the morning, because in the morning, that's when your cardiovascular system is under the most strain. That vast majority of heart attacks occur in the morning. And that is the pain caused by lack of blood supply to a region of the heart, again, normally caused by an atheroma or an atherosclerotic plaque. Now, that's quite a manageable condition. It does require further investigation, but because it's predictable, it's quite manageable. Now, sometimes things begin to get a bit worse. Sometimes angina just presents as unstable angina. Now, generally, if someone's got angina and they suddenly start complaining of pain on less and less exertion, so perhaps they might have had a bit of heart pain when they were jogging, but if they toned it down a bit, they're okay. Now they might start to be getting pain when they're going for a walk. It could be that they're even starting to get pain when they're sitting down doing nothing. And that's when the angina's got stable. And that unstable angina is normally caused by a ruptured atheroma. So the atherosclerotic plaque that's narrowed the artery is probably at this point ruptured. Okay, and it's causing a sort of a whole host of blood clots and thrombus formation and so on. And that's quite severe, and often next step there is a full-on myocardial infarction or heart attack. It's worth bearing in mind that there are other types of angina. So stable angina and unstable angina tend to be due to the larger arteries in the heart. We also get variant angina, which again is more rare, often due to that spasm or constriction of arteries. Again, that spasm or constriction tends to be associated with an atheroma as well. The other one is microvascular angina, and that's due to the much smaller blood vessels. The pain with this type of angina tends to be much more severe because it's those smaller blood vessels that actually supply directly the heart muscle. So the signal or loss of blood supply might be more severe, and they don't often respond to the normal treatments for angina. Now, I think I mentioned previously cardiovascular disease in women, often it is less noticeable, and that's also because women tend to get variant angina and microvascular angina a bit more often than men do. The other thing is women tend to mention that pain pattern. They tend to have an atypical pain pattern compared to men. Almost all experiments in the lab and historically have been done on men, and therefore all the pain patterns are represented by male studies. So again, worth bearing in mind, pain in the back, down the right arm, things like that can also be signs of cardiovascular disease. Very important to recognize that that can be different in men and women. So the next step, if you like, is myocardial infarction. Now, what we're calling a myocardial infarction is when you've had a ruptured atherosclerotic plaque, the atheroma is ruptured, and you've got thrombus formation, or maybe that thrombus has broken up and you've got embolism of blood vessels further down. And most of what you call the classical heart attack of the chest pain and then having the heart attack, that is actually myocardial infarction. You can see it's not too far a step away from unstable angina as well. When this has happened, normally you've got complete loss of oxygen to an area of the heart, and you've got complete loss of oxygen to the area of the heart supplied by that particular artery. So you can imagine if there's a block in one of the branches further down that only supplies a small region of the heart, the consequences are perhaps less severe. If you've got a block in one of the major arteries to the heart and it's a full block, you're going to be damaging quite a large region of the heart muscle. And when you have prolonged loss of oxygen, what tends to happen is you get irreversible cell death, and that's often the process called apoptosis. The cells know they're going to die, so they start killing themselves. And you also get, and that tends to be a more controlled manner, you also get necrosis. and that's when basically the dying cell starts killing neighboring cells as well. That's in very simplistic terminology. The other problem is when you lose oxygen supply to a region of the heart, that loss of oxygen is causing damage. Your next problem is when you restore oxygen flow to that region, if it's been hypoxic for a long time, the restoring of the oxygen causes even more damage. So you get what you call an ischemia reperfusion injury. So again, you can't just go in, even though most of the treatments are about restoring blood flow, restoring blood flow can sometimes also cause quite a bit of damage. Now, there's lots of different treatments to restore blood supply and also to prevent what we call prevent reocclusion. In other words, prevent the artery from blocking again. And we also have treatments to try and minimize the cell death in the long term as well. So basically, in myocardial infarction, if we take a section of the blood vessel there, we have an atheroma, then forms a thrombus, and that thrombus goes on to cause embolism. And I don't think I will talk through that in too much detail. There is a video I could play now. I'm not going to play it now. It's kind of fairly obvious that if you have block of an artery, the plaque ruptures, or the atheroma gets so big that the area is blocked, you're going to prevent that blood reaching the heart muscle downstream. So all this heart muscle here above the block is going to be okay. Everything downstream is going to be damaged. Now the problem with myocardial infarction, and if we go back to that video at the beginning, is that it can be very hard to diagnose. The symptoms are very similar to angina. So often someone who has angina, who's having a particularly bad angina attack, might be just like, oh, it's fine, it's just angina, but they haven't realized it's progressed. And that's why if you experience abnormal heart pain when you have angina, it's very important if it gets worse to immediately call an ambulance. Because again, like in the video, even with the stresses on the NHS at the moment, a heart attack or potential myocardial infarction is always going to be a priority. And time is the absolute key in treatment. The quicker you can get someone from the pain presenting to treatment in the hospital, the better. And the aim for treatment is really to be ideally less than an hour, but certainly less than 2 hours. And that can really affect where you live. Reading is actually probably one of the best places in the UK to have a heart attack. It's got the best cardiac unit. There's all sorts of reasons for that. It's because of the size of the geography of Reading, as well as having a really good cardiac care team. It's also, the reality is, most people in the catchment area for the Royal Berkshire Hospital are within a 45-minute drive. So it's not just there's time for the ambulance to get out to the person, bring them back in. And that is the key for treatment. So if you live out in the sticks, you know, your chances aren't as high as someone who lives next door to the hospital. Treatment time really is key. Now, traditionally, when I say traditionally, we're talking about 3 factors. Then the World Health Organization decided on this in 1979, and you can still use these factors to help diagnose a myocardial infarction. Again, these days, particularly in the UK, we tend not to bother, and we just tend to treat as if any presentation is a myocardial infarction and then worry about the consequences later. Generally, if a patient has a history of chest pain, angina, then that's increasing the risk that the call out is for myocardial infarction. If you measure the ECG, and you did that last year, and I will tell you all about ECGs again after the week 6, then there's certain changes in ECG that can be characteristic of a myocardial infarction and an ischemic attack. And again, anyone who is being picked up for this will be immediately strapped up onto an ECG machine. But the most important thing is the cardiac biomarkers, and one in particular, which is troponin. Now, troponin is released by damaged muscle. So if troponin levels go up, then it's an indicator that you have damaged muscle. Now, obviously, if someone's just been for a workout, their troponin levels are going to be up, so they're going to be slightly higher than normal. But in a heart attack, if the troponin levels are greater than the 99th percentile, then it's classified as a myocardial infarction. So you don't need the patient history, you don't need to know anything about the ECG. If you know those troponin levels, that's what decides treatment for myocardial infarction. And that again is graded in severity from 1 to 5. I'm not going to bother talking about that today because again, often the treatment doesn't change rapidly. Probably the only other major thing is once it's established it's a myocardial infarction is again the ECG recording. And if you remember, the ECG recording consists of a P wave, that's atrial contraction, the QRS complex, and the T wave as well. And there's two main types of myocardial infarction classification. In some patients, if the ST segment, so it's this segment to this segment, is elevated, then imaginatively it's called ST elevated myocardial infarction, STEMI. Okay, and if that section isn't elevated, appears to be normal, then we call it non-ST elevated myocardial infarction, NSTEMI. And in general, most people think of NSTEMI as being less serious than STEMI, and until recently that's probably the case. If you had an NSTEMI, your chances of survival and long-term survival were greater. Fortunately, these days treatment for STEMI has improved quite a lot, and your chances are about equal about 12 months after the heart attack. Okay, so I'm a pharmacologist. I love to talk about drugs, so I'm going to talk about the drugs that are used. I want you to bear in mind that the key treatment in myocardial infarction and often even severe angina is actually to have a stent put in. It's surgery. It's basically to have a piece of wire or inserted through an artery in the leg into where the blockage is, and then that wire frame is pushed out and sort of removes the block or widens the artery, and it remains in place and keeps the artery open. And that's the main treatment. But there are lots and lots of drugs used in the prophylaxis, in other words, to prevent, and also the treatment of ischemic heart disease and coronary heart disease. So lots of different types. The ones I'm going to talk about are the organic nitrates, and they're particularly in terms of treatment of angina. And again, certain prophylactic ones, which means they treat the symptoms and also prevent the chances of having an angina attack or MI. And again, we have the organic nitrates, the beta blockers in particular, although also the calcium antagonists. And we also have antithrombolytic and antiplatelet agents, and our friends, the ACE inhibitors as well. Again, can't highlight enough, the key thing there is surgical interventions, and in virtually every case of myocardial infarction, there'll be some form of revascularization, unless for some reason it's not safe to do so for the patient. And that's what we call angioplasty. So if we look or organic nitrates first. Now, organic nitrates have been with us for a long time, and it's a British physician called Lord de Brunton really first discovered amyl nitrate use could relieve angina pain back in 1867, and some of you might be familiar or have heard of amyl nitrate. It's occasionally used as a party drug, occasionally used as a sexual aid. Its other name is poppers, and that has this very similar effect to the drugs used clinically, such as glycerol trinitrate or GTM. Again, that is also organic nitrate. Of interest to any history buffs, organic nitrates were first discovered as a byproduct of making dynamite. So you've heard of the Nobel Prize. Well, the Nobel family, Axel Nobel, the company, made their cash from making dynamite, and eventually, as a byproduct of that, they've also made something that saved lots of people's lives as well. And apparently, the Nobel Prize was originally developed because he felt so guilty about all the people that died due to the invention of dynamite that that he invented the prize for medicine and achievements in science. Now, all of these organic nitrates cause relaxation of vascular smooth muscle and other smooth muscle cell types, but here we're focusing on vascular smooth muscle, and that's because in solution these compounds release nitric oxides spontaneously. So if you put them into aqueous solution, they release nitric oxide. That nitric oxide generates cyclic GMP in the smooth muscle cells, and we'll talk more about cyclic GMP in the aorta practical. The key thing here is that the organic nitrates dilate coronary arteries and they redistribute blood to the ischemic regions, and I'll speak about that in a moment. The other effect is they also reduce the cardiac output because they also dilate the veins that supply the heart. If you dilate the veins, you get less blood returning to your heart, less venous return. If you get less venous return, it reduces the cardiac output, and that's based on the Frank-Starling mechanisms that you were taught in first year. So again, glycerol trinitrate used quite a lot. This is really purposes. Now, the problem with organic nitrates is that they are very prone to tolerance. And this was first noticed again in explosive factories. People working in explosive or ammunition factories would go into work on a Monday, get a blinding headache, but they kind of develop tolerance to that by the weekend. They'd have a break from exposure, come back on Monday, feel like crap, blinding headache, and so on. And it's exactly the same in patients with coronary heart disease. They have to have nitrate-free periods, and normally in that usage is overnight's enough because the amounts of exposure are a lot less. But if you keep on exposing someone to these nitrates really quickly, you get used to them and they don't have any effect. The other problem they have is that the action is short. Now that's not a problem if you have an angina attack, because you might just want to relieve that angina attack. But they also have a really short half-life and therefore need to be replaced regularly. And if you're not regularly replacing them, then they go off very quickly and they're not as effective when you go to use them. And again, that can lead to hospitalization. So GTN normally is a sublingual tablet and often as a spray or sublingual tablet. Again, they cause flushing. Your face tends to go bright red, a headache, and postural hypertension. I'm an inquisitive soul, so my dad has got cardiovascular disease, and I just, I had a go on his GTN once, and it was awful. I felt shocking. Yeah. Sorry?
In which condition does it have to keep being repeated? Because you said it's not an angina.
It's not a...
You said in angina it's not a problem if it's short acting.
Oh, it's not short acting because often a period of angina pain is often quite a short period of pain, and it's often quite predictable. So often you take the spray, and the effect of the drug, as I was explaining, is quite horrible, pounding headache and flushing. But it's enough to restore the blood flow to the region of the heart that needs it during that angina attack. So it's very good as kind of prophylaxis, so that when you're experiencing the pain, you can take it. Yeah, but obviously, if you take more than a couple of sprays in a row and it's still not tackling the pain, then A, you're at risk of getting intolerance. B, whatever's causing the pain and the loss of oxygen is persisting. Therefore, it's probably a more serious situation. So if you look at the guidance for taking an angina spray like GTN, it will tell you if it's not worked after so many sprays, hospital, because it could be an MI. Did that answer your question? Okay. So this is a kind of quite complex slide. I'll try and speed up a little bit. What we're looking at here is, imagine this is the blood supply to the heart muscle. Now, where this artery branches, you have one of the arteries has a plaque. So you're getting less blood going down the direction of the of where the plaque is, and then the other artery, the heart muscle, is normally perfused. So what it means is you get an area of the heart which has less blood, and that's what we call the ischemic area, and that's the area where you'll experience that heart pain and the angina pain. Now, the reason nitrates are used is because not all vasodilators are effective at treating angina. Some vasodilators can make angina worse. Okay, so what an organic nitrate does is, as well as dilating the normal region of the heart, it will dilate the region supplied by this artery that's got an atheroma. But again, the blood supply is going to be less in that region. But the body has lots of backup systems, so there's lots of what we call collateral arteries, and they're basically shunts between regions where blood can be redirected. And what organic nitrates are very good is dilating these collateral arteries and redirecting blood flow to the region of the heart that was suffering ischemia. So what you get is a redistribution of the blood so that there's no region that is ischemic. That kills the angina pain. Other vasodilator drugs, such as dipyridamole, which isn't really clinically used, what they do is they dilate both of these artery branches, but they don't tend to dilate these collateral arteries. Now, this artery doesn't have a plaque in it, so if it's fully dilated, more blood is going to go down this route. This artery does again dilate, but it's blocked by a plaque. So actually what happens is, if you use the wrong type of vasodilator drug, you begin to steal blood from the ischemic area, and you actually make the ischemia worse. And again, clinically, we do actually exploit this phenomena, because quite often with people who have angina, they will go for what's called a cardiac stress test. And during a cardiac stress test, essentially, if the patient can't exercise or isn't very mobile, you want to see if it is angina. You stress the heart a little bit to see if you can provoke angina, and that's what you do. You use a dilator that doesn't dilate those collateral vessels, and it helps establish that Okay, so now we're back to drugs that I've already spoken about, the calcium channel blockers. And again, calcium channel blockers are good in prophylaxis of angina because they are vasodilators, but they also reduce the heart rate and the force of contraction. And again, you can find out more about this in the hypertension lectures and the interactive lectures, and also my arrhythmia lectures that you'll get in a couple of weeks. Calcium channel blockers, like organic nitrates, dilate those collateral arteries, and they reduce the oxygen demand for the heart. That's quite important because angina pain is due to a lack of oxygen. There's two ways of dealing with a lack of oxygen: is either give more oxygen or reduce the need for oxygen. So these drugs do that. Again, the ones most commonly used are diltiazem and verapamil. I talked about those tissue selective calcium channel blockers in my previous lecture. Verapamil is by far the most cardioselective. Diltiazem has a mixed action. The dihydropyridine type, less commonly used in treatment or prophylaxis of angina, and certainly the original dihydropyridine type, nifedipine, is avoided in angina because of the reflex tachycardia. It can actually provoke an angina attack and actually increase mortality following a myocardial infarction, which I've mentioned there. Again, the side effects are rare and similar as to what I covered in the hypertension lectures. Again, just highlighting diltiazem there. It's not in your interactive lecture. So what I want to focus on here is the beta blocker class of drugs. So I mentioned in the last lecture that beta blockers were actually specifically designed for treatment of angina. Before beta blockers came along, there were organic nitrates, which come with their problems of short action and tolerance. And literally around this time, if you think of treatment for heart disease in the 1950s, there was nothing. If you ever look at the Twitter feed, which I don't think anyone does, that's on the PM2C feed, I've put a graph showing how heart disease has decreased. And actually, heart disease has massively decreased, starting around about the 1950s, 1960s, round about when beta blockers came in. And the person who invented them, who I was lucky enough to work for, was Sir James Black, and he won the Nobel Prize in 1988. He developed this class of drugs, and also, for any statos out there, he also invented histamine antagonists as well. And what he realized, or what his genius idea was he realized that at the time in the 1950s, people were trying to supply more oxygen to the heart. But if you take the oxygen saturation of the blood of someone who has angina, it's no different to someone who doesn't have angina. It's about 98–99% saturated. There's not much room to play with. You can give someone oxygen, but their blood's already saturated with oxygen. It's not going to help. So what he realized was you need to reduce the demand of the heart for oxygen. And he went back to first principles and thought, well, what stimulates the heart to need more oxygen? The sympathetic nervous system. If I block the sympathetic nervous system on the heart, I will block the action I'll block that action, and therefore reduce the oxygen demand, and therefore reduce the angina. And that's exactly what these beta blockers do. They block the beta-1 adrenergic receptor in the heart and do precisely that. Another nice, interesting caveat about how these drugs were developed is this was done in Britain. And again, in the 1950s, things were a bit different. They did it on a dog. They developed the beta blockers with a chemist, made the chemical, stuck it into a dog, had the desired effect, reduced cardiac output. So then they thought, brilliant, it's worked on the dog, let's get the technician in, and tried it on the technician. Did nothing. And they were in a real panic, thinking, well, why has it not worked? And then they had two technicians, and one of the other technicians was actually a bit of a portly fellow, and well, basically he was obese, and they found it did reduce his cardiac output, and they sort of clicked that maybe this drug would work in people who need it the most, who tend to be obese, tend to have heart problems in the first place. Very little effect on normal people. The unwanted effects I've already covered in the previous lecture, and you might also see more of those unwanted effects in the heart as well. Again, there's little effect of beta blockers on resting heart rate or cardiac output, or indeed blood pressure. And as I just mentioned, in most people who don't have a heart problem or high blood pressure, that's of little consequence, these actions. But what they do is they reduce the effect of exercise or excitement in the heart. And again, if we go back, think about the 1950s, people were literally getting frights. You know, like people like, oh, don't give me a shock, you give me a heart attack. That was literally happening. These people were getting a shock and dying because there was no treatment for myocardial infarction. That kind of comes to an end after beta blockers come in. So they basically just reduce the sympathetic drive and therefore lower the demand the oxygen has for the heart. They kill that angina pain, but also make it more unlikely that you experience the angina pain in the first place. Also, these drugs have an effect on the heart rhythm. Again, I'm not going to cover that today. But the one thing I do want you to remember today, beta blocker drugs do not dilate blood vessels. I cannot make that any clearer. The number of times I've heard that beta blockers reduce angina pain because they dilate blood vessels, it's simply not true. It's a common misconception. Beta blockers have very little effect on the blood flow. It is the other drugs, the calcium channel blockers and the organic nitrates, that dilate the blood vessels. Beta blockers, no. Very little effect on peripheral resistance. Okay, so I'm going to finish off today talking about management of coronary heart diseases. And I'm trying to get an expert cardiac pharmacist to come in and talk to you, to give you the pharmacist's perspective of working in a cardiovascular unit and what the pharmacist does there. Unfortunately, my contact for that has since left the hospital, so I'm trying to find a new contact who's prepared to come and talk to you. So hopefully over the next 2 or 3 weeks I can arrange a session where we can do that. Feedback from previous years is always found extremely useful, and you also get a chance to ask them questions that can help feed into your PBL case studies. The other thing, which I've already mentioned, is angioplasty surgery is very regularly used in the treatment of coronary heart disease. And I've said NI, I meant MI there. Almost universally following a myocardial infarction. There are also a number of nice guidances related around coronary heart disease, and I've just listed them there for your information, that gives you the different treatments for different types of angina. And again, you'll find looking over those particular guidances and the evidence those guidances contain particularly useful for your PBL. So if we look in rough terms at management of stable angina, the key drugs here are organic nitrates. Again, if you've got predictable pain, you can just take a short puff of the organic nitrate just to get rid of that pain. And for a lot of people, that's enough in the short term. Generally, if it's a little bit more severe, or almost universally, normally the patient will also be given a beta blocker, because beta blockers are particularly effective at preventing angina attacks and reducing the pain during an angina attack as well. Calcium channel blockers are also licensed and are quite effective at that, but they're generally reserved for patients who a beta blocker is contraindicated, or for patients who have left ventricular dysfunction, which beta blockers can worsen. Again, the reasons behind that are complex. If you look at long-term reduction in mortality, beta blockers are slightly better at secondary prevention as well of cardiovascular events and primary prevention. A combination of beta blocker and calcium channel blocker can be used in patients who have angina that's resistant to treatment with just one of them. Long term, you need to have secondary prevention. So if you don't want to have a myocardial infarction, or you don't want the stable angina to get worse. So again, low dose aspirin, about 75 milligrams as an antiplatelet. Almost everybody will be offered a statin. Again, major cause of coronary heart disease is a major cause of coronary heart disease is atherosclerotic plaques. Cholesterol is involved in that process. Statins help reduce that. Statins also have other effects called pleiotropic effects, which also help reduce heart disease. And again, ACE inhibitors will generally be used while they do have direct effects on the heart. They also reduce total peripheral resistance, so they make the heart work less hard. Heart works less hard, less oxygen it needs. Fairly simple. When we move to angina and NSTEMI or non-ST elevated myocardial infarction, generally oxygen will be used in immediate treatment only if there's evidence that the patient has hypoxia. So if you've ever seen or in the presence of someone in an ambulance team, often one of the first things they'll do is they'll clip that person to a little oxygen monitor on their finger, test that. Often they'll be given a nitrate tablet and quite possibly a shot of morphine as well, because the pain of this is intense, extremely intense. The next step is probably surgery, and then following surgery, you'll be given what we call dual antiplatelet therapy. That's aspirin and one other type of antiplatelet drug. That tends to be clopidogrel. And of course, beta blockers or calcium channel blockers in long term and other secondary prevention, very similar to just angina on its own. Again, for ST elevated myocardial infarction, treatment is very similar. Again, angioplasty tends to be the key treatment. Might also include fibrinolytic drugs. In other words, drugs that, if you like, bust the clot, because that kind of clotting is more serious in ST elevated myocardial infarction. And again, guidelines for that vary enormously, not just across the UK, but also across different countries. Again, the prophylaxis is very similar. Statins, aspirin, ACE inhibitors, beta blockers, and in STEMI, you'd also include clopidogrel, and that clopidogrel will be used for a much longer period post the MI. In some cases, you might get warfarin, but that's particularly unusual these days. Very important with the calcium channel blockers, only verapamil or diltiazem can be used to replace a beta blocker in some patients. No others are used these days. So I'm going to end just mentioning that angioplasty, and just to highlight that what we're talking about here is stents that are placed into the narrowed artery. Normally the way that's done is an endoscope containing the stent on a sort of inflatable balloon is inserted into one of the arteries in your arm. Or your leg, your femoral artery, and that's fed all the way through to your cardiac muscle. Then the stent is put into place where the blockage is, the balloon is inflated and that expands the stent out, and that crushes the plaque backwards and also keeps the artery in an open state. Then the stent is removed. So quite a simple treatment. Stenting is also beginning to be used for treatment of strokes as well, although there it's a lot more rare. So quite a, again, I'm not video, and I'm not going to show you the video of a coronary heart bypass either, because that actually is quite a graphic video of a coronary surgery. But it's worth bearing in mind, sometimes a stent isn't enough, and you'll hear about a bypass surgery. Here, a vein is taken from somewhere else in the person's body and basically plugged into the aorta and bypasses the region where the block of the artery occurs. Okay, so again, thanks for listening. Don't forget to read the information about the PBL, because we're going to start the PBL after week 6 quite rapidly. I expect you to have met in your groups before that first session to at least discuss your case study. The information is all on Blackboard.